transanal local excision. Transanal local excision is standard guidelines is usually is done for only T1 tumors, which is less than 3 centimeter, involving less than 30% of circumference of the bowel, no LVSA, no lymph nodes, well differentiated or moderately differentiated tumors, and uh, these all the tumors where you can go transanal excision. Like if you have tumors up to 8 centimeter, you can remove even with the transanal micro invasive surgery. Whereas above 8 centimeter, why it's not usually transanally is not accepted is because these tumors can go into peritoneal infection and peritoneum can get contaminated. So they're coming to the radical procedures. There are the two types of radical procedures. So in gauze, one is sphincter preserving procedures that includes the ultra low anti-resection and the intersphincter resections. For internal sphincter resection, they are classified as partial intersphincter resections or the total intersphincter resections. If you know that according to anatomy, the internal muscle layer is continuous as the internal sphincter, whereas the levator ana is attached and continue as the external sphincter, and there is a plane between the internal sphincter and the external sphincter known as the intersphincteric plane. Okay, these tumors, when they are involving the intersphincteric plane, they are not considered for the sphincter preservation, oncologically not safe. If adequate margins are given, you can give ultra low anti-resection. If in the second diagram you can see the tumor is intersphincteric plane is not involved, but it is the tumor is close to the internal sphincter. Here you can consider doing a partial intersphincter resection, whereas the total intersphincter resection is occurs when the sphincter muscle is involved. Okay, when the intersphincteric place involved, you have to do a sphincter sacrificing surgeries, which are of two types. One is abdominal perineal resection. Here the specimen is hourglass specimen, whereas the extra-levator abdominal perineal resection is done when the levator muscle is involved, where you have to give the margins to the levator also. That is known as extra-levator abdominal perineal resection. Here the specimen is cylindrical in shape because there is no constriction level at the level of levator ana attachment. So in coming to the colon, as the total mesocolic excision is the standard of care in rectal cancers, here the standard of care is complete mesocolic excision. Complete mesocolic excision is nothing but central venous ligation of the vessels are done, and the mesentery is totally removed without any of the spillage of the tumors. So the minimally invasive colectomy is also considered as part of the treatment, and nowadays it's not usually recommended for tumors which are the acutely obstructed tumors or perforated tumors, where this minimally invasive colon dissection is not accepted. There are various trials that have been proven to establish a role of minimally invasive tumors, but in minimally invasive tumors, minimally invasive surgeries have to be done only by the expertise, and there should not be compromise. Okay. Now coming to the colorectal cancer with peritoneal disease. The peritoneal disease in any of the colorectal cancers or pseudomyxoma peritonei or even with ovarian malignancies, there is a terminology known as PCA score. This is nothing but peritoneal cancer index score. You can see the various regions. So the regions are in totally 13 in number. Our abdomen is divided into 9 compartments and 4 compartments in the small bubble. That includes upper jejunum, lower jejunum, upper ileum, and lower ileum. In that, there is also known as a lesion size score is there. For each compartment, you categorize a lesion size score. Lesion size score 0 is no tumor is seen. Lesion size score 1 is tumor up to 0.5 centimeter. Lesion size 2 is tumor size is up to 5 centimeter. Lesion size 3 is tumor up to 5 centimeter, and there is a confluence.